the basic art of crossing, of handling of specimen, and also the science of the reporting, pathology reporting. And it needs a good teamwork, including the technologists, pathologists, assistants, and also even the surgical oncologist. Now, pathology is a very blooming subject. It's an ever-changing subject. A good synoptic report is now essential for keeping the data elements in specific formats. And a surgical oncologist is concerned about the marginal status of the tumor, and also accurate grading, staging, and molecular studies are other ancillary studies are very much essential for predicting patient outcome. So we receive specimen as cytological smears or histological sections. So histology includes tiny elements like core biopsy and also excisional biopsy. We know there are several indications for core biopsy. Patient may present with a mass or without a mass. So the mass can have some microcalcifications in it, or it may not have any microcalcification, or the mass might be very small. And even the patient can present without any symptom or sign. Only on scanning mammography, we may find some microcalcifications, specifically those which are worrying, like clustered microcalcification or pleomorphic type of microcalcifications. In those cases, core biopsy is indicated. Now, as we know, already Dr. Rupa has mentioned anything about core biopsy. I'll not go into much details. We know that it is usually taken under ultrasound guidance, which traditionally been the first choice. But however, stereotactic core biopsy is more effective to avoid the underestimation of a sinister lesion and also for accurate sampling. So we can do it under MRI guidance or with assistance of a vacuum-assisted technique, which is called a mammotome biopsy machine. So after taking the course, we can do specimen radiography, which is of much importance to differentiate the course into calcified and non-calcified elements, so that we can give more emphasis or more attention to the calcified course after keeping it in the cassette and taking different levels and examining thoroughly for any sinister lesion. So specimen radiography is an important tool. Here is the difference between the cytology and the core biopsy, which I think the audience knows very well, that cytology are smears, dispersed cells, small clusters, and the histopathology, like core biopsy, even though it is a small tissue, but it shows the architecture, it shows the tumor type, and many other things we can conclude from a core biopsy for better management. So a core biopsy report may include the tumor subtype, whether it is invasive or in situ in type. Even we report that what is the maximum extent of invasive focus in the particular core. And also we note down whether there is any accompanying in situ component or not. And usually what in my practice I do is I do not do the total grading from the core biopsy, I just do the nuclear grading. Because these are thin strips, I'm not seeing the whole tumor. So we do, it's better to do nuclear grading of both the invasive carcinoma and the DCIS or LCIS. And also there are some other features which will indicate the nature of the tumor, whether it will be more sinister or it will rapidly be metastasized, like retraction cleft artifact or lymphovascular space invasion and wide areas of necrosis. These are the things which we can figure out from the core biopsy. And also, nonetheless, we can do receptor status. We can do immunohistochemistry for further identification of the tumor. Now, some more points about the preservation, tissue preservation, which is quite important. This is the cold ischemic time, which is very important. The cold ischemic time is the time period or interval between the removal of the tissue from the body and up to the immersion of the tissue within the fixative before sending it to the laboratory. So it should not exceed more than 1 hour. That is very important. And the fixative time, as we all know, most of us know that 10% neutral buffered formalin is a very ideal fixative. And also fixation time should not be less than 6 hours and should not go beyond 72 hours before we start the processing. So these things are very simple, but very, very important for getting a good hematoxylin and eosin stained slide to look through the morphology of the tumor, and also for the ancillary studies like immunohistochemistry, ER-PR HER2 status, and also for fish. Now to come to the synoptic reporting, this is critical for patient management, as we all know. And also synoptic reporting is critical for cancer surveillance. It helps in cancer surveillance, which is important. In our country, we should go for the cancer surveillance, and we should keep our structural data set. So if we do it in a structural fashion, doing a synoptic reporting is very important for our patient management as well as for research purpose. Now this picture shows the most of the cases we nowadays are getting the breast conservative surgery, which are mostly post-neoadjuvant chemotherapy cases. So whatever the size of the specimen is, whether it is rounded or irregular or oval, we just visualize the specimen as a rectangle, as been shown in this picture. This is our visualization, whatever the shape of the specimen is. We have to visualize it as a rectangle with having 6 faces. So what we do with those faces, we use some tissue colors. These colors are important for identifying the margins, all 6 margins, and we using the brushes, having strokes on those faces. Like this specimen, we are getting this specimen. If it comes in a sutured or oriented way, we can easily identify the margins very perfectly by assuming it as a rectangle, and then we are coloring all the sides. Here is the anterior surface. There is a template for coloring the specimen. So this is the anterior surface of the specimen. There is a small skin flap attached, which is colored orange. We can see other colors beyond on the periphery. So why do we use the colors? So we use the colors to see whether there is involvement of any particular margin, whether if it is not involved, what is the distance of the tumor from that particular margin. This is very important for the surgeon for re-excision or other purpose. So this is a color template, which is usually there is an universal color template for some institutions. In my practice, I'm using this template. And after, as you see in this picture, after applying the colors, the 6 different colors on 6 faces, namely superior, inferior, medial, lateral, anterior, posterior. So after applying the color, we are making slices of the specimen and then keeping it further in formalin for some more time and putting some tissue papers or hard cards inside so that the tissue doesn't get distorted. And you can see here the slices having multiple colors on their margins to indicate that particular margin. So here is a recent paper published by Canadian pathologists and pathologists' assistants last year in March, they have proposed a revised grossing technique, revised grossing style for post-neoadjuvant breast cancer specimens. There is standardized guideline for residual cancer burden that is called RCB. So there is an RCB score, which is a clinically validated, easy to use web-based tool, and a more accurate specimen sampling is very crucial to get a reproducible result. And we can see in this picture how sections are chosen, and more attention is given to the tumor center, where we are getting the marker, the copper wire or the hydrogel marker. So the specimen photography, section mapping, tumor size, tumor cellularity, extent of DCIS, lymph node status, etc. are given special attention for doing the RCB score. So the RCB score is very important for patients who continue to have residual disease after neoadjuvant therapy. So we can see under microscope, the slides look like this, and there are the margins which are very evident, very clearly evident that this is the green margin. It indicates the superior margin. If we find a tumor over here, what is the distance we can measure? So and so. So I'm going to the mastectomy specimen. The mastectomy, in case of mastectomy specimens, we color into two colors only. This is a discoid lesion, discoid specimen having two faces. We color the anterior surface orange and the posterior surface black. And then we do the sectioning. We slice the specimen into 8 to 10 slices, starting from medial to lateral. We locate the tumor. We see the position of the tumor. We note down the slices or slice which is involved by the tumor, and then we locate the clock position, and then we measure the distance of the tumor from all the margins, superior, inferior, medial, lateral, and all, and even the deep margin. And in the meantime, we put the specimen further into formalin for better fixation for working on it on next day. And in the meantime, we do the axillary dissection. We take out the lymph nodes. And in suspicious cases of cancer, it is very important that we take at least 12 lymph nodes from the axillary tail. However small it is, we have to take it out. It's a challenge for us to take out as much lymph node as possible. So here is a mastectomy specimen. What are the sections we are taking? Usually we take section from the nipple, perpendicular sections, including the nipple areola and the subareola. We take section from the tumor. We take a complete cross-section of the tumor, and then we divide it into 2, 3, or 4 parts, depending on the size of the tumor. And then we take sections from all the margins, including the deep margin. It's very important to take the deep margin, especially when the tumor is on the deeper aspect of the breast. Also, we take sections from all 4 quadrants of the breast, including the apparently normal-looking breast tissue, to look for any DCIS or any early breast cancer. And also, in cases when the tumor is near the skin, we have to take perpendicular section, including the skin and the tumor, to look for any invasion into the dermal lymphatics or invasion into the dermis or epidermis or the epidermis, to call it stage 4B. And nonetheless, if there are more than one tumor, we have to take section in between the tumor, the healthy tissue in between the tumor, and then examine it. And it is not so easy to call it a multifocal tumor, because it may be an extension from one tumor to the other. Apparently, it may look like multifocal, but it should not. It should be histopathologically excluded by taking section in between the tumors. So coming to the reporting, which is the CAP guideline for standard reporting, we in synoptic reporting, what we usually note down are the procedure, specimen laterality, as we all know, tumor site, tumor size, and histologic type, histologic grade. And also we go for architecture, detailed architecture to do the grading. The proper grading should be done by considering three important issues like glandular tubular differentiation, nuclear pleomorphism, mitotic score, etc. And also then we have to indicate whether it is a unifocal or multifocal tumor. And also we have to, nowadays it is very important to note down the tumor infiltrating lymphocytes, whether it is low, intermediate, or high. So a high, it is, in short, it can be called as TIL. If it is high, a high TIL is usually associated with increased PD-L1 activity, and usually triple negative breast cancers are associated with high TIL. And in some cases of ERPR negative, HER2 positive breast cancers also tend to have high TIL. So this is very important for predicting tumor behavior. This picture shows two very beautiful pictures of DCIS. One is very low grade and the other one is a high grade one. The low grade one on the left side, we can see it's of cribriform type, and the cells are very noble and they are not very aggressive looking. And if we do on the left side, right side of the this photo shows the high grade tumor. It's a Comedo type DCIS having area of necrosis within the center of the lesion. It's the high grade lesion. High grade DCIS usually indicates a more sinister type of breast cancer. It has more propensity to involve the regional lymph nodes. Now coming to the DCIS more elaborately, we have to examine the number of blocks. We have to count the number of blocks we have examined, and then we count number of blocks having DCIS in it. And also we look for the presence or absence of EIC, which stands for extensive intraductal component or extensive DCIS. Some of the tumors have got extensive DCIS along with the invasive component. If the DCIS constitutes more than 25% of the tumor mass, then it is called EIC positive. So that is also a very important parameter. We also look for the extent of the DCIS. We have to measure the extent of the DCIS. That is also very important. And also the nuclear grade of the DCIS. And of course, the type of DCIS, whether it is solid or Comedo or low grade like cribriform, etc. We also look for the margins. As we know, the margins are important. And if it is negative, it's okay. But if it is positive, we have to indicate whether the margin is unifocally positive or multifocally positive, or there is extensive involvement of the margin. These are very important issues to decide the tumor character. And also, in case of regional lymph nodes, we have to examine for micrometastasis, macrometastasis, or isolated tumor cells. So we have to take more sections from the lymph node as more as possible to look for isolated tumor cells or micrometastasis, which is hard to find. So micrometastasis means the metastatic focus starting from 0.2 millimeter up to 2 millimeter in size. And isolated tumor cells means less than 200 cells, tumor cells in a deposit, metastatic deposit. So these are very hard to find, very subtle, and we have to look for the micro and isolated tumor cells by taking several sections, taking levels, doing more sectionings. And then nonetheless, lymphovascular invasion is also very important, and we also have to look for any dermal lymphovascular invasion. So these are the two pictures showing invasive ductal carcinoma, the low grade and the high grade type. We can see the low grade type has got some regular fashion, some tubular structures we can see, some glandular things are present still then, and the cells are also very small, and there is less pleomorphism. But in the right side, we can see the high-grade lesion. It looks so aggressive. It looks angry and busy, and the cells are very bizarre. And some tumor giant cells are even seen, and the nuclei are also pleomorphic with a prominent nucleoli, etc. So another important point, which is very, very important nowadays for a synoptic reporting, is the treatment effect, which the surgeons and radiologists, radio-oncologists and medical oncologists need to know from us. So treatment effect of breast cancer, we have to determine whether there is any treatment, because most of the cases we are getting more and more resected specimens, post-neoadjuvant specimens. We have to look for is there any reduction in size of the tumor, or is there any partial reduction, a complete disappearance of the tumor, which is known as PCR. So these are very important issues, even for not only for the invasive part, but also for the lymph node. Also, we have to note down the treatment effect, like whether the lymph nodes were having any metastatic deposit. Has that metastatic deposit completely disappeared or not? That is a PCR also. So receptor status, everybody knows we do receptor status, and also we do FISH in cases of equivocal HER2 positive cases. And lastly, we do pathological staging, TNM, AJCC 8th edition. We know everything very well. I don't think I should elaborate on these too much. And this picture shows the HER2 two types. The HER2 report, we report like negative, positive, and equivocal, which is also designated as HER2 2+. So this is weak to moderate complete membrane positivity. We have to find weak to, even if it is weak to moderate and it is complete membrane positivity, we have to find it in more than 10% of the tumor cells, and then we call it HER2 2+. But when it is intense and uniform, and we find it in more than 10% of tumor cells, we call it HER2 3+. So in HER2 2+ or equivocal cases, we go for further molecular test to see the genetic mapping within the cell by doing the fluorescent in situ hybridization technique, and that also everybody knows. So lastly, I'll talk about some TNM descriptors as we use for our reporting purpose, like small p stands for pathological stage, C stands for clinical stage, M stands for multiple foci of invasive carcinoma, R for recurrent, Y for the post-neoadjuvant specimen. So in summary, we can say a good histopathology report has got both diagnostic and prognostic significance, and also we should emphasize on getting more and more oriented specimen to us for generating a proper synoptic report, so as that we can help the patient as far as we could. Thank you very much for your attention.